So now we are going to return to the question of use of PARPs, but in the recurrent setting. But before we do that, it's important to try to tackle once again this definition of platinum-sensitive versus platinum-resistant recurrence. Mike, I'll turn that over to you.
Cannot believe you're going to ask me that question. You're the father of platinum sensitivity and
It was easy
resistance.
in those days.
So, and again, you did the hard work at the right time to pretty much define what we've used in the field for years, which is a 6-month cutoff for recurrence, defining patients earlier than that as resistant and patients after that as sensitive. What's changed the equation is the fact we now have maintenance therapy. So if a patient is on bevacizumab or a PARP inhibitor and now recurs at 9 months, is that equivalent to the old defined patient as platinum sensitive, or has the biology changed? My suspicion is that if it's Bev, it probably doesn't make a difference because it works on a different mechanism. But PARP, I'm not so sure because it's affecting DNA repair, but we don't know the answer to that. And then add on to that, now a lot of our patients have 7, 8, 9 regimens. So if they're out at 8 regimens and they recur at 8 months, is that still the platinum-sensitive patient we used to talk about? So these things are complicated. The truth is, I think practically in the clinic, a lot of us are still using the 6-month cutoff. Zamora, you live on. And in clinical trials, most of the time it's defined that way.
But Mike, to your point, I think it's a spectrum. I don't think that we should automatically rule out platinum or platinum combinations in patients who are who might recur right at 6 months. And you know, it's a somewhat arbitrary cutoff, but it does again help with our counseling of patients in terms of the toxicity of our regimen versus the benefit.
Since this has been such a informative panel, I thought I would just throw out to my colleagues for a couple of comments on the potential role in the future of immunotherapy, checkpoint inhibitors in the management of ovarian cancer. Trials are ongoing. There have been some negatives. Any thoughts? And then we'll talk about recurrent disease.
Well, so far single agents have been disappointing. Response rates have been between 9 and 12 or 13%. That clearly has not stopped the field, though, because the last time I summarized this on a slide, I couldn't fit all the trials on the slide. It was over 45. I think the most interesting thing that I've seen is this combination of IO with PARPs, like the Topaccio study, you know, the idea that a tumor that has a DNA repair problem might have more neoantigens. I don't know if I buy that, but there's certainly pretty good data that these tumors activate the STING pathway, and the STING pathway produces interferon, and that can activate T cells. So combining these drugs, I think, has a rationale.
And even in the platinum-resistant patients in Topaccio, you had about a 25% response rate across the board, which is impressive in that patient population. So
I think there was even a few refractory in there.
But then you know, we had the failure of the 2 Javelin trials. We will have Imagine 50 out with the Atezo combination. We have Athena coming out probably in about 4 years, and we have 2 trials, the first and the Duo trial, that are going to throw everything at the tumor. So we'll have a lot of data. We just don't have it now. So I think to be determined.
You know, the interesting thing is, I think IO demonstrates where oncology has evolved to. You know, in our days, there was actually a lot of hemming and hawing about what's the science behind it, whatever, so on and so forth. But, you know, the Javelin trials are designed very quickly. These are $100 million experiments, basically. So I think that's bad news for drug development. I think it's in some ways good for patients, though, because the field is moving so fast. We get answers.